Good morning, and thank you for joining us. My name is Dawn Cullum, and I am the Senior Events and Training Coordinator for Certara University. As regulators and sponsors, Certara recognizes the growing importance of model-informed drug development. We are committed to educating the next generation of experts in this field by partnering with eminent scientists at designated academic centers of excellence around the world. This year, our Express webinars are being conducted by our partners and centers of excellence. Today, Dr. Stephen Balevic is our presenter. Dr. Balevic is an adult and pediatric rheumatologist at Duke University and Associate Director of Pharmacometrics and Small Trials at the Duke Clinical Research Institute. His research interests are clinical trials and precision medicine through population pharmacokinetic and pharmacodynamic modeling. He completed his PhD in pharmaceutical sciences at UNC Eshelman School of Pharmacy, and today we'll be presenting research from his dissertation that investigated novel study designs to advance pharmacometric modeling and simulation in vulnerable populations. Dr. Balevic, I turn it over to you.
Great. Well, thank you very much for that kind introduction and for the invitation to speak. So today we'll be presenting some data from my dissertation research, which broadly was looking at different types of study designs where we could really support modeling and simulation in understudied populations. And so I'll be providing, as an example of this approach, hydroxychloroquine PK in pregnancies that were complicated by systemic lupus. I've listed here my disclosures for your reference. And I'd like to start by talking about some brief background on the challenges of clinical trials in pregnancy and also in other vulnerable populations. And then we'll talk briefly about systemic lupus and hydroxychloroquine and some of the study design that we used. So unfortunately, as probably many of you are aware, most clinical trials in vulnerable populations, such as pregnant women, fail to achieve labeling indications. And this is a major problem because up to 2/3 of pregnant women may use a drug in pregnancy, with the majority of those unfortunately being off-label. Now, a common reason for trial failure is poor dose selection because many studies don't account for the physiologic changes that can alter drug disposition. And make matters worse, there's a number of ethical challenges to conducting traditional PK studies in pregnant women and also in children and other vulnerable populations as well. So, for example, we may not have the safety or the dosing information necessary to safely expose a pregnant woman to a study drug. And so it's almost a catch-22. We don't have the necessary PK data, but we still need to conduct clinical trials to be able to use these drugs safely. And so, collectively, these challenges have really resulted in a significant lack of PK/PD data to guide appropriate dosing. So then really what we need then are new sort of minimal risk study designs where we leverage a real world data approach to overcome some of these ethical limitations so that ultimately we can get the PK data we need to optimize dosing in pregnancy. And so the study design I'll be specifically talking about today is a disease registry. So a disease registry, you can really think about this like a prospective observational cohort. And so we can enroll patients who are already receiving a drug of interest for clinical care, likely off-label. And so because this is an observational sort of study design, we are not, exposing anybody to a drug for study purposes. And so that makes it minimal risk, right? Rather, we're allowing the clinicians to decide, if the benefit outweighs the risk for these patients and manage that prescription. Now, the other major advantage is that we can enroll patients with a disease of interest, right? So we can study a drug in its intended population. Now, while disease registries are really sort of an innovative solution to overcoming some of these challenges of PK studies in pregnancy, it may also have its limitations. So, for example, a lot of these registries are not designed to collect the data that we traditionally need for PK modeling, such as, rich dosing history, for example. And then we also have to be considerate of other real-world challenges like medication non-adherence. And so I'll sort of provide some examples of some problems that we encountered and some solutions we came to overcome those challenges. I did want to touch briefly on systemic lupus. So systemic lupus is a very rare autoimmune disease. So it impacts about 1 in 1,000 people in the United States. It's a lifelong autoimmune disorder where the immune system can cause damage and inflammation in virtually any organ system in the body. So unfortunately, in pregnant women who have active systemic lupus, so we'll call it lupus for short, poor neonatal outcomes are common and can be devastating. So this can be preterm birth or critical care hospitalization, for example. And we know that if there's increased inflammation during the pregnancy, it could significantly worsen outcome. So for example, women with lupus can deliver preterm about 1/3 of the time just at baseline. But if their lupus is active and there's ongoing inflammation in that pregnancy, up to 2/3 can deliver preterm. So this really underscores why we have to use drugs like hydroxychloroquine, which is our gold standard immune modulating drug in pregnancy to reduce disease activity. Now, we do know that there is a therapeutic window for hydroxychloroquine in non-pregnant adults, but we don't really know what that therapeutic window is in pregnancy, and whether target drug concentrations may not be achievable due to some of these physiologic changes. And so I'll review in just a few moments how some of these changes may impact drug exposure. So I'd like to briefly review hydroxychloroquine pharmacokinetics, and then again how it may be changed in pregnancy. So on the left side, we'll briefly review the drug's ADME, so absorption, distribution, metabolism, and elimination. Now on the right-hand side, I'll sort of highlight how that parameter may be changed in pregnancy. So hydroxychloroquine is overall very well absorbed, but has very, very high inter-individual variability in the extent of absorption, really for unknown reasons. And in pregnancy, there's increased gastric pH and decreased bowel motility, which again could all impact absorption. The drug has a very, very large volume of distribution, so 44,000 liters in plasma. And in pregnancy, there's increases in both total body water and total body fat, which again could potentially increase the drug's volume of distribution. The drug is metabolized by multiple cytochrome P450s, including CYP3A4, which does have increased activity in pregnancy. And then a little under half of the drug is excreted renally. It has a very, very long half-life of about 40 days. And in pregnancy, there's significant increases in the glomerular filtration rate and other renal changes as well, which again could potentially increase hydroxychloroquine clearance. Now, despite the potential for all of these physiologic changes to impact drug disposition, there's very little data to support hydroxychloroquine PK in pregnancy. So to really answer this question, then we conducted an observational and PK analysis using data from the Duke Autoimmunity and Pregnancy Registry. And as I alluded to earlier, this is a sort of prospective longitudinal cohort where we collect research data opportunistically, which means at the same time of routine clinical care. So the number of visits a patient may have, again, just depends on their clinical needs. But each time a patient is seen in the clinic, we obtain a serum to measure drug concentrations. And so this averages about 2 to 3 times throughout pregnancy and postpartum. Again, hydroxychloroquine is administered per the treating clinician. And so it's not a prescription that we control as part of a study or for research purposes. Now, importantly, the administration date and time is not known for all the participants. And so, again, I'll talk a little bit later about how we approach that for our modeling and simulation. So from this registry, we included pregnant women from 2013 to 2020 with lupus, all who were on this drug for at least 3 months. We assumed they were at steady state and excluded those with multiple gestations. Drug concentration was analyzed using a validated commercially available assay, and then we conducted nonlinear mixed effect modeling with Phoenix and LMA. Now, as I alluded to, one of the challenges in studying a drug in the outpatient setting is this idea of medication adherence. And so we oftentimes take that for granted because as modelers, we may be used to working with clinical trial data sets, right, where maybe patients are admitted to a early phase unit and are directly administered a drug. And so we have this very precise dosing history. We know patients received the drug because maybe a nurse administered it. But when we're doing an outpatient study, especially over the course of an entire pregnancy, medication adherence may become an important factor. And so we measured this in a subset of patients using this self-reported inventory. And so this is a validated 6-item questionnaire that, based on the response, at any visit, we can dichotomize a patient as being recently adherent or not adherent. And so I'd like to switch gears and we'll talk about our results. And I would like to point out that this data was recently published in Lupus Science and Medicine. So if you're interested in learning a little bit more about the methods and the results, please check out this manuscript. So in terms of our results, so we enrolled a total of 56 women who had 61 pregnancies and 202 visits. And so you can see the clinical characteristics here. And on the right-hand side, the samples. So we obtained a total of 202 samples. And it's probably worth pausing there because, remember, this is a very rare disease in a vulnerable population. And so the fact that we were able to obtain this number of samples in pregnancies, I think, does speak to the feasibility of this design. So about 10% of the samples were beneath the quantifiable limit, but you can see we were able to obtain blood really throughout each trimester and postpartum, so a really good distribution of samples. Now, in terms of dosing and administration times, hydroxychloroquine is typically administered as a 400 milligram dosage once a day, and that was by far the most common regimen we saw for about 3/4 of patients. But again, there was a little bit of variability in the dosing and administration. Now, as I alluded to earlier, the date and time of hydroxychloroquine administration was only known for about 1/3 of these visits. And so for the visits where it was unknown, we imputed an administration time of 8 o'clock in the morning on the day of that clinic visit, with the rationale being that the drug's half-life of 40 days is so long, the within-day variability is very, very low. But again, I'll talk about how we approach that assumption in a few moments. And then again, we had adherence measures in a subset of patients as well. So the first thing we wanted to do was really to characterize the effect of medication non-adherence on drug exposure. From a modeling perspective, if you think about the impact of non-adherence, right, patients who are non-adherent to their medication have very, very low drug concentrations. And so from a modeling perspective, that could lead to biased estimates, right? In particular, perhaps clearance, right? We may be overestimating clearance if we have a cohort of patients where there's a lot of medication non-adherence. And so to really take a look at this, we analyzed drug concentrations in those patients who had that Mausry score. And so on the y-axis here, we have drug concentration, x-axis, based on that score, whether they were classified as non-adherent or adherent. And we found that patients classified as non-adherent had an average concentration of around 100 nanograms per ml. It's about 2.5-fold higher in those who were adherent. And so, if we use sort of this cutoff of 100 nanograms per ml as a threshold, about 1 in 4 visits, had these low concentrations, suggesting non-adherence was fairly common in this population. And that corresponds with what we see clinically. We know that lupus being a chronic autoimmune disease, and especially in pregnancy, where there may be things like nausea and vomiting that can further make it difficult to take medications, that this estimate seems to be on par with what's been reported elsewhere. So then next we wanted to develop a population PK model for this drug in pregnant women with lupus. And I'll just briefly go over sort of our model development. So we started by exploring 1 and 2 compartment structural models with additive, proportional, and combined error models. We initially estimated between subject variability for all parameters, and then remove those with high shrinkage. And then ultimately, we select a final base model based on what has the lowest objection function value, precision, plausibility parameter estimates, and various diagnostic plots. And so what we found for hydroxychloroquine was that a 1-compartment model with proportional error really had the best fit. We did fix the absorption rate and lag time based on some literature values. But you can see here, there was very, very high inter-individual variability for apparent oral clearance. So it was 139, and then very high residual error as well, so 60% sort of unexplained error. And so when we looked at individual observed versus model predicted concentrations, we saw a few different patterns develop. So the first pattern were patients where we have imprecise administration history, right? So that was patients where we imputed that 8 o'clock administration time. So on the y-axis, we have drug concentration, x-axis time. This black line represents the model predicted concentrations, and the circles, the observations. And so you can see when we don't know their administration history very precisely, the model doesn't capture the observations very well. Then we have another sort of subset of patients who are classified as being medication non-adherence. And you can see again that the model has difficulty sort of characterizing this data. And then we have patients who are classified as adherent and who we had their administration records precisely. And so you can see the model captures these concentrations much, much better. So then what we did is we went back and we restricted and sort of refit the base model, but we restricted this to subjects who, we had precise date and time of administration for hydroxychloroquine, and we excluded visits with concentrations less than 100. Again, with the rationale being that those patients, based on that Maudsley score, are consistent with medication non-adherence. And so when we refit this base model, we overall found a substantial improvement. So the residual error was reduced from 60% down to 23%. And the individual variability on clearance was reduced from 139 down to 39. And so again, you can see overall that there was some improvement in the model performance. And then if we look to the right, you can again see that the black line here are the model predicted concentrations, and these squares the observations. And so the model is able to capture even unusual looking time concentration profiles. All right, so if we take a step back, it appears then that medication non-adherence and inaccuracies or unknown data administration times, was impacting the sort of model performance. And so then we sort of took that base model and carried it forward to do our covariate search. And so based on these between subject variability or ADA versus covariate plots, we saw several potential relationships with the parent clearance. So we then conducted a forward inclusion and backward elimination approach. And we found that body weight was a significant covariate on volume of distribution, and trimester, right, which is sort of a way to look at pregnancy duration, was a significant covariate for clearance. And so I've listed here our final PK model sort of in its algebraic expressions. And here's our final model parameter estimates. And so by including these covariates of weight on apparent volume and trimester on apparent clearance, we're able to reduce the inter-individual variability slightly more, as well as the proportional error. And I've just included here, just for reference, some of the diagnostic plots for our final PK model. So on the y-axis, we have our observed concentrations, and x-axis individual predicted concentrations. And you can see most fall along the line of unity. And B, we have our population predicted concentrations. C and D are condition weighted residuals, and we didn't see any clear systematic bias. And then E is our QQ plot. And then lastly is our predicted correction visual predictive check. And so the gray shaded area here represents the 90% prediction interval, and these circles the observations. And so you can see the majority of concentrations fell within that 90% prediction interval. Okay, so now that we've developed this PK model, well, what can we do with it? And is there anything that can help us from a clinical perspective? And because we found that trimester was a significant covariate on our PK parameters as well as weight, we were able to then go back and look at the post hoc or EBE parameter estimates for, apparent clearance and volume and half-life. So let's look at half-life, for example. So we found that the postpartum half-life was about 32 days. And again, this is sort of the closest we have to the non-pregnant values. But we can see the half-life drops from 32 days down to 21 days during pregnancy. And apparent clearance increases from 33 liters per hour postpartum up to 53 liters. And we also saw an increase in volume and distribution related to weight in pregnancy as well. And so this is really the first time we've ever been able to characterize how pregnancy physiology changes hydroxychloroquine disposition in pregnancy. But importantly, we wanted to quantify not only the impact of physiology changes, but medication adherence as well. And so we then conducted some dosing simulations where we used our final PK model. We generated a virtual population of 1,000 pregnant women, so 250 from each trimester and postpartum. We used the same distribution of weights as in our study population, and then we simulated the expected steady state concentration for the most common dosage, so 400 milligrams taken once daily for at least 3 months. And then using some R code, we went through and deleted at random 20%, 40%, or 60% missing doses. And so this, again, was a way for us to sort of impute different degrees of medication non-adherence in our model. So on our left, we have these results. And so on the y-axis, we have the median hydroxychloroquine concentration, x-axis time. This is assuming no missing doses, right? So oftentimes when we do dosing simulations, we sort of assume every dose is taken. So this top line is represents the postpartum concentration, the red line here, first trimester, and then second and third trimester beneath it. So again, you can sort of see visually the impact of the increased clearance in volume in pregnancy on drug concentrations. And then on the right, this was the worst case scenario. So this is when we imputed 60% missing doses or 60% non-adherence. And you can see there's sort of this additive effect. We have very low hydroxychloroquine concentrations throughout pregnancy. And so again, using this approach, this is really the first time we're able to sort of see the individual but combined impact of both physiology and medication non-adherence. And so why is this important? Well, because it allows us as clinicians to use therapeutic drug monitoring to identify medication non-adherence. And this is a very important tool for us to have clinically. So then using these dosing simulations, we looked at various cutoffs for hydroxychloroquine, so here in this first column. And then in the table, these numbers represent the percentage of expected low concentrations or concentrations at that threshold. So let me give you an example. So if we use a cutoff of less than or equal to 100, a patient taking 400 milligrams once daily of hydroxychloroquine should only have a concentration less than 100 0.3% of the time, or we only observe that 0.3% of the time in our dosing simulations. But you can see if a patient is 60% non-adherent, then up to 1 in 4 concentrations will be consistent with non-adherence, or less than 100 rather. And so that was actually very consistent with what we saw in our cohort, right? Almost 1 in 4 visits had these very low concentrations. And so this aligns well with what we've seen in other studies as well. So again, this really allowed us to have a clinically useful measure of medication non-adherence. And so we're actually starting to incorporate this now in our clinical practice. And then lastly, we wanted to perform an exposure response analysis for this drug in lupus. And so there were 56 pregnancies with known outcomes, 2 neonatal losses, and about a third of the population delivered preterm. So again, fairly consistent with the background rate in lupus. And then we were very interested in determining what the impact was of these low concentrations, so that less than or equal to 100 group. And so in our logistic regression modeling, pregnancies where there was this average concentration less than 100 were associated with an 11-fold higher odds of preterm birth, even when we controlled for confounders. Now, it's important to note here that these low concentrations, this is a correlation, but not necessarily a causation, right? So we don't know, is this therapeutic failure because the drug's not working, or are these low concentrations, again, a surrogate for non-adherence, and maybe non-adherence to hydroxychloroquine is a marker for non-adherence to other medications or pregnancy care in general. But regardless, it certainly seems to be a predictor of poor neonatal outcomes. So then in conclusion, if we take a step back and think about this from a study design perspective, we found that using this opportunistic sparse sampling PK approach within a disease registry was really a novel way to collect samples in a rare disease and again in a pregnant population. but limitations in the data set, so not having dosing records for all patients, and again, medication non-adherence accounted for a lot of residual error in the PK model, and we had to modify our data set to be able to account for that. But despite these potential limitations, we were the first ones to identify significant changes to hydroxychloroquine PK in pregnancy, and we identified this important signal that low concentrations were consistent with medication non-adherence, and we can use TDM to potentially help identify pregnancies at risk for poor outcomes. This will allow us hopefully to do some interventions at improving medication adherence. So with that in mind, I'd like to thank members of my dissertation advisory committee, as well as just the entire UNC Eshelman School of Pharmacy. I'd like to thank Dr. Close, who's the principal investigator for this cohort, as well as Dr. Hornick, one of my mentors, and of course, patients and their families who contributed this data. And so with that in mind, I'm happy to help answer any questions that arise.
Awesome. Thank you, Dr. Balevic. I do have a couple of questions. If anyone else would like to ask questions, please put it in the question section of your dashboard. Dr. Balevic, in your study, you found that there were challenges to using real-world data sets such as medication non-adherence. What are some of the other challenges to developing PK models using real-world data?
Yes, that's a fantastic question. Yeah, thanks so much. I think using these opportunistic designs where we don't control the prescription, again, is really novel in that it's minimal risk. But because we're not directly controlling the prescription, it can be very, very challenging, especially over the course of a long study like this one, to get all the dosing changes that may happen. So for example, let's use COVID-19 pandemic as an example. Patients may call because they acquired COVID-19, and their clinician may direct them to temporarily stop a medication, whether it's hydroxychloroquine or something else entirely. And so that change, then maybe that holding of the medication for a certain period, this is always captured in the medical record, or especially in the research data set. Or for other rheumatic diseases, we may have patients taking corticosteroids, and that corticosteroid dose we may increase or decrease depending on whether there's a flare or not. And so, again, if you think about the dosing data set over the course of a several-month outpatient study, there may be medication changes that are not always captured. And so that can, again, make it difficult from a PK modeling perspective and can take some unique solutions to be able to capture this. And whether that's giving patients a journal to take home with them where they're writing down these medication changes, there's several different solutions to overcome that, but it is something that has to be thought of ahead of time when doing this type of study.
Great, thank you. The next question, can you speak to some of the other study designs that can be used to study drug PK in the vulnerable populations?
Yeah, sure. Yeah, thank you. That's a great question. The other two study designs that we looked at as part of this project, so one was still an opportunistic PK study, but it was what we call a PK trial. And this basically meant instead of collecting data at the same time of routine clinical care, we actually had dedicated study visits. And so the only intervention, though, is PK sampling. So we still didn't control the prescription for this other drug. But we could bring patients back to do timed PK sampling. And so instead of being a sparse PK sampling approach, it was a much more rich PK sampling approach. Another way to do this is to target the diseases where patients have to be admitted to the hospital for something. So for example, preterm labor. When patients are admitted to the hospital, again, we now have access to much more precise dosing administrations. It takes medication non-adherence out of the equation. And again, we can do much more rich sampling in the hospital setting. And so that's sort of another spin on the opportunistic study design.
Okay. How do you determine the TDM target drug levels?
So that's a very good question. You know, for hydroxychloroquine, there's sort of a growing body of literature where different investigators have tried looking at the association between drug concentration and different outcomes. You know, for our study, you know, what we were able to do was to look at the relationship between, again, those low concentrations and then neonatal outcomes of interest. But in these type of opportunistic studies, it can sometimes be challenging. And so, you know, I think the lesson there is it's important to try to include some outcome measure, whether that's a PD marker or a clinical outcome in the data set, and then really leveraging you know, experience in the non-pregnancy population to at least try to get an idea of what the therapeutic target may be. But again, in pregnancy, things may be different, and so it does require its own study.
Great. Well, Dr. Balevic, thank you so much for your presentation and for being with us today. Our next webinar is going to be on September the 20th, and it will be presented by Dr. Kagan from Rutgers University. And as you see on our last slide, we have all the titles and registrations for the rest of our webinars. And we look forward to you joining us again. Thanks so much.
Thank you very much.